to notice a lot of extra people on this Zoom beyond council members. I think it's great that Ray has invited much of the staff, which is super, to do much of the presentation. And I think that is a wonderful addition. It is a bit of an experiment, so bear with us as we go through this process. And there is a whole lot of things to cover. There will be no votes, but there is a lot of material. And I hope people feel very free asking questions and trying to interrupt. After each presentation, there'll be time for questions, but if you want to interrupt, Ray and the speakers have promised that if you unmute yourself and you look like you're eager to talk, they will try to notice you and make sure that they stop and ask if you have anything that you'd like to add or ask a question. So, okay, let's start with approval of the minutes. They went out, I was very impressed, they went out on Saturday. So does anybody have any comments, questions on the minutes of the last meeting in June? If not, do I hear a motion?
So moved.
Second?
Second.
Thank you, Meredith. Ray, I will then turn it over to you to introduce the various speakers, but I know that you're going to open up with an executive director's report.
Yes, thank you very much, Chair Donahue. Good morning, everyone. Thank you for coming to CHIA's virtual Oversight Council meeting, or second time we've used this new format of not meeting in person. I think as we're all learning with remote work, it has some advantages and disadvantages. So we'll hopefully take advantage of as many of its strengths as possible. This will be a more participatory meeting than we had in June when things were still developing very quickly. So this time we'll be having more speakers, and we're hoping that that'll go well. The agenda for today's meeting, why don't we perhaps put that up on the screen briefly while I talk through the agenda. There, thank you very much. So having approved the minutes, I'm going to start off giving an executive director's report. It will actually be very brief, and then I'm going to turn it over. Those bullets that you see under the executive director's report are all actually presentations that will be given by someone other than myself, other than myself. The review that you see there are the NATO 35th Annual Conference and Academy Health Annual Research Meeting. We're incorporating a video montage into today's meeting. It's summaries of presentations that CHIA staff did at these at the annual meetings of these organizations. One of the themes of this meeting is that we do want to showcase the breadth and depth of CHIA's work and our staff. And so we wanted to find ways to incorporate more CHIA staff members into today's meeting. There's enough people involved in these two different presentations, or the two different national conferences, that we felt that it would involve too many handoffs. So we're trying a video montage. We'll see how that works. Anyway, so after the executive director's report and those pieces of it presented by other folks, we're going to turn to three more standalone presentations on recent work that CHIA has done of interest and importance to the Oversight Council and others. First, we're going to be talking about the hospital financial performance during COVID-19. One of the things that you'll hear about during my executive director's report is that we've been working very hard to accelerate our data collection and reporting activities because during COVID, there's intense interest in how things are developing. And so we have accelerated our collection of hospital financial data. We have more insights into hospital financial performance now than we otherwise would by quite a bit. And so you'll hear from the team that did the data collection and presentation work. After that, you'll be hearing a report on how CHIA does data linking. This is really becoming an essential service that we provide, both for people that want to use CHIA data, but also for just other agencies that are, well, like I said, I guess CHIA data is always involved, but sometimes it's really very much a matter of matching to a population that somebody has in mind and giving them data back. Other times it's using the technology to let agencies, in particular the Department of Public Health, run things like their public health data warehouse. So it's a integral component of the way that they can assemble multiple databases to get an integrated view of public health in the Commonwealth. So really interesting and important service. I can't do it justice. And so you'll hear directly from Mike Kochi, CHIA's CIO and Chief Data Officer, on how we do that. And then after that, we'll get a presentation on the results of CHIA's 2019 health insurance survey. We do two major surveys, one of employers, one of households. This is the 2019 household survey. We were planning to roll it out in the spring to some amount of fanfare, but we were overtaken by events. But it's very important work, very interesting results, and it gets at, frankly, a lot of the issues that we want to be looking at in light of the pandemic and in light of the increased focus on health equity issues. So anyway, that's a summary of the agenda. If you could do the next slide, please. Okay, so we're going to do the executive director's report. I intentionally didn't do slides because the meeting is already somewhat slide heavy, and so I didn't want to overemphasize the amount of time that we're spending with slides up on the screen. So I have my own versions of these. I think shortly we'll switch back to more of the panel view of all the attendees in the meeting, because I think it's nice to use the power of these video conferencing technologies to be able to see the different people, see the names of the faces, and not look at slides if they're purely static, as is the case here. Later on, when we're getting presentations on projects that are much more detailed and the slides convey a lot of substance, it's of course important to have the slides on the screen. But in a minute, we'll pivot back to the panel view of speakers. I just wanted to quickly review. There's six topics that I'm going to touch on briefly, and then I'll be turning the floor over to Deb Scheel, who'll be doing an update on CHIA's APCD initiative. It's the biggest project the agency has done, in 10 years. It's the biggest project we'll do for the next 10 years. It's a really foundational platform for us. I'm very pleased to say that we're near the end and we're still getting essentially everything that we had hoped for when we set out in this path. So really credit to Deb and her team and all the people at CHIA that have been working on it. So you'll hear a report on that. And then I guess I shouldn't tell what I'm gonna stop there rather than moving forward with the preview and go through the items on the executive director's report. But why don't we switch back to the panel view of speakers, and we can switch back to the screen view or the slide view as necessary. So as you saw, the executive director's report had 6 items on it. The first is the finance update. CHIA's finances continue to be something that we focus on very carefully. We ended fiscal 20 with a balanced budget. Again, it involved the use of capital. It's been an unusual year or a challenging year for the state. And so for a bunch of reasons, a lot of issues for the legislature and the administration to focus on. So the bond vehicle that we were using for the funding was somewhat late in passing. So we were late in getting that funding, or somewhat late in the cycle. But I believe everything is now actually, all the transfers have taken place. If not, they're essentially in the works. And so CHIA has ended fiscal 20 with a balanced budget and making all the necessary transfers to the Community Hospital Reinvestment Trust Fund. As for fiscal 21, we're starting out the year with some assumptions, but we're also assuming that it's going to be a challenging year. And so there's a premium on being frugal, on being smart, and being flexible. So we'll, obviously keep the council informed, and we're working closely with administration and finance and health and human services on all of these issues. But fiscal 21, I'll be honest, we can't really speak to it in great detail, other than kind of the starting point, but how it develops over the next 9 months, we're going to have to see. I'll stop there. I don't know if either people have any questions, or Cassandra, if you have any thing that you want to add to that. I know it's fairly high level, but it's also, we do try to spare the council kind of the nitty gritty, but each year, as I said, we do balance the budget.
I don't really have anything to add. I think that did a great job of capturing the situation, especially as to FY21. There's great uncertainty at this point, but we can kind of go based on the assumptions that we have and the interim budget that we're operating under. And we hope for a GAA at some point soon, but until then, we just have to be frugal and plan to the best of our ability. And I think CHIA is doing a great job of that, and in communication with our budget team. So I think that covers it.
Great, thank you. I don't know if council members have any questions on the finances. If not, I'll move on to an update on 2 sort of major CHIA data collection and reporting activities that we've delayed. But this is, and we talked in June about the huge impact that COVID was having on CHIA's operations. But I'm happy to report, and I won't go into it at length because we talked about this in June, but we've made a remarkable transition to remote work. We're essentially doing our entire book of business that we were doing prior to COVID. We've flexed that agenda somewhat because we didn't want to impose undue burdens on providers and payers at this time. So we've delayed some of our data collection, but we've also accelerated a number of data collections on a voluntary basis so that we can get a better view of what's happening with COVID. So we're very busy with a whole bunch of activities. Normally, we'd be rolling out our annual report right about now. It would be very nearly done. We'd be getting ready to meet with the HPC privately to go over it with them, and soon we would publish it, and the whole fall cost trends hearing process would start. This year, of course, that's not happening because of the impact of COVID. CHIA delayed the data collection that feeds into the benchmarking process, the calculation of total healthcare expenditures and total medical expenses. We delayed that data collection from May to September to give the data submitters more time. There are actually some advantages to a September timeframe, we think. We're going to find that out. But as a result of that delayed data submission, we won't be publishing the annual report until probably February of 2021. And this is something that we've worked very closely with the Health Policy Commission on. They're well aware of this. They've brought this up at some of their recent meetings. Other than the unfortunate separation in time from the period being measured to the publication of the report, there are actually some advantages. But this year in particular, it was simply dictated by events. So I just wanted to inform folks that the CHIA annual report is going to happen in full. The data is actually coming in this month, but the actual publication will not happen until February of 2021. Similarly, this year we were planning to roll out a major new initiative to collect a bunch of information about primary care and behavioral health spending. The annual report always looks at total healthcare expenditures and how they grew year over year, but we then break it down into some really interesting and important buckets, like how much of the total spending was inpatient, how much of the total spending was outpatient, how much was on physician services, how much was on drugs, things like that. So it's a really interesting and important breakdown. But the Baker administration filed legislation to start measuring how much organizations were spending on primary care and behavioral health services. And we were aware of this, and we decided that rather than wait until the law passed, we could anticipate the law and start collecting the data right now, because that way you have the factual foundation established sooner in the process. Well, as a result of COVID, we're not going to be, the legislature doesn't appear to be taking up the governor's primary care behavioral health initiative. But we are going to proceed with collecting the data. And what that means is that when the legislature actually addresses this issue, they will have a much richer foundation for making decisions than they had initially. So the data collection is going to be happening in December of this year, and the publication, this is the first time ever with that. So I don't know that we have a specific plans yet for what we're doing in the way of publication, but we will have that data and be in a position to analyze it by the end of this year. I guess I would just mention, I'd mentioned earlier that we have accelerated our data collection in a number of ways. So the last two that I just mentioned involved delays, but we are also accelerating various data collections, including case mix, including accelerated reporting on things like enrollment trends, which we'll talk to you about next time. And we're accelerating our collection of hospital financial data. So you'll be getting a report on that a little bit later in this Oversight Council meeting, but I think it highlights the way CHIA has responded to the crisis in a number of ways, but one of them is with much faster data collection and reporting. And one example I like to use is that last year we published our first ever intended to be annual report on the nursing home industry in Massachusetts. And so the thought was that there would be an annual cadence. We're now in the business of daily data collection and reporting from nursing facilities. Now it's for the command center, but we're building into our DNA, if you will, the capability to collect and report on data much, much faster than we ever did before. So you'll hear a really cool report on how we're doing that with hospital financial data, and that's letting us see the impact COVID's having on hospital finances.
Ray,
yes.
Sorry, real quick on that first data set, for the annual report. I know that you said that it should be, you pushed that back to September. I just wanted to make sure, double check that. Are you anticipating any further delays in that data, or you've seen any problems with it coming in this month? Or
I think everything, if anybody on staff can speak up, but need not. I know all indications are that it's very well in hand. I mean, the hospitals and health plans in Massachusetts have responded remarkably well to the crisis, and they seem to really appreciate the importance of. They're being pressed very hard by the federal government and others on brand new reporting duties, but I think our sense is that all the deadlines we've put out are being adhered to pretty well. We're feeling quite confident.
Awesome. Thanks, Ray.
Any other questions on that? I just have two last items on my executive director's report before I'm done. One was to mention, and you'll be hearing from Mike Kochi, our CIO and Chief Data Officer later, about the linking work we do. I did also want to mention that this month is significant in that we've finally left our data center. For years, CHIA has had its IT infrastructure in a very high-end Tier 1 data center with a lot of the other sort of premier organizations in the greater Boston area share a particular data center. I'm sure there are other excellent ones, but we're at a very, very good one. But we have now completed our migration to the cloud. So we are freed of a lot of the burdens associated with managing that infrastructure. Managing a giant cloud infrastructure, or maybe that's not a giant cloud service contract, comes with its own challenges, which we're addressing. But it's been a project long in coming, a lot of planning, a lot of work. And the organization has successfully poured, and we run lots and lots and lots of applications and platforms and processes. We have lots of analysts banging up against lots of data sets. There's a whole lot of IT infrastructure that underlies what CHIA does. And we've now, and I think there may be, sort of a tail on it, but by and large, we are completely out of our data center and have moved to the cloud. And that frees up, as I said, I think it makes a lot of things possible. So I'll pause there in case anybody has any questions on that. Or if you think of any, as Mike's starting to talk about linking, you can throw him a curveball and ask him a question about the data center. All right. And then the last item that I wanted to speak to is just to let people know we'll definitely do a presentation on this in future meetings. We had a whole bunch of ideas for things we wanted to present to you on at this meeting, but there's really quite a bit as you'll see as we go forward. But we did want to talk about the issue of health equity. It's something that's extremely important, and it's obviously taking on greater importance in the last 6-9 months because of the death of George Floyd and other events, and increased focus on just COVID itself has focused attention on how racial disparities and other disparities in the healthcare system result in disparate outcomes when things like a pandemic happen. So CHIA is very keen to do what we can to shine a brighter light on these issues, not just ourselves, but really to make sure the data is there so that that foundation exists for others to do their work, because the Health Policy Commission in particular will be doing, I think, a lot in this area. And we want to be sure that we're anticipating that as much as possible and creating the resources that they and others need to tackle these issues. For us, it kind of comes down to, I mean, we've done actually a bunch in this area already. So for years, CHIA has been reporting on hospital readmissions, but there was a recognition that not all populations, it's a little unfair to hold hospitals to the same standard for all populations in terms of readmissions, because we know that people with behavioral health conditions are more likely to have difficulty complying with what you need to do to stay out of the hospital. Access to, a pharmacy. There may be other reasons that people have difficulty doing the things they need to do to stay out of the hospital. So CHIA worked with a bunch of people from the Department of Public Health, from the University of Massachusetts and other places, private sector experts, to come up with a methodology for adjusting the way we look at readmissions to take into account social risk factors. So we've done a bunch of work in this area to look at race, ethnicity, geography, disability, language, other things, poverty, access to transportation services, housing insecurity, on and on. We've done a bunch of work in this area, but not nearly enough. So we're going to do more. Candidly, our work with claims data is hindered by some federal regulations that make it very difficult for us to get particularly granular. We have to de-identify the data. And getting extremely granular around race and ethnicity and such makes it very easy to identify the person. And so that's challenging. But outside of our claims data, we're doing a lot of work with case mix. That's hospital discharges, emergency department visits, observation stays. There are less restrictions on the data we collect from hospitals. We're not seeing the whole system, but we have very good race and ethnicity data. would love to see it get better. We have a better geographic information that we're hoping to leverage. So a bunch of things that we're planning to do around our hospital data that we hope will help us shine a better light on health equity issues. In addition, the aggregate reporting that CHIA does. So every year as part of the annual report, we collect a lot of information on healthcare spending in Massachusetts. We make the health plans break that down by geography, by member zip code. So there's a lot more that CHIA could do and others, looking at how much money actually gets spent on services to people based on where they live. And the Attorney General's office did an analysis like this some years ago. I think that I mean, not surprisingly, but disappointingly concluded that we spend a lot more money on people that live in rich towns than people that live in poor towns, when it should really vary more by your health condition and not by, just that geography. So anyway, we're doing a lot of work with our hospital data, but also with aggregate data to help understand health disparities. And then lastly, I'll mention the health insurance survey that you're going to hear more about later in this presentation. That very specifically, it's a survey. It's not, so it has the strength of a survey, has some of the, the difficulties and limitations of a survey, but we're actually talking to 5,000 Massachusetts households. It already goes into a lot of detail and has a wealth of information about not just access and coverage to health insurance, but about race, ethnicity, disability, behavioral health issues, a lot of things like that. So we can certainly do more, but this is an example of where I say, when you hear what we've done, I think you can listen to it both in terms of the current analysis, but also think about how we can apply this to the current issues, in particular the pandemic and health equity. All right, that's it for the presentations that I wanted to do. I'll turn the floor over next to Deb Shield. She is Chief Analytic Officer, and she will give us an update on the All-Payer Claims Database project, which just continues to excite me to no end. I've been involved as a non-expert, but been involved with the APCD movement, if you will, for over a decade. And the initial hope of what they could be was very unrealistic, I guess, in terms of the complexity of the data and what's involved in really making that happen. We've been a leading state for years, and I think we're really on the verge of creating a platform for using claims data that really lives up to the hope people originally had for it. So it's really a credit to Deb's team and the great work that they've done. For us, it's an enterprise platform that we're really hoping the whole agency will be using. We also hope that it's something that's heavily used by our sister agencies. So I'll stop there. Before you take over, Deb, that I'll pause because I think that's it for me. I mean, I'm going to obviously be here, but that's the executive director's report. And as I said, this will be a more participatory meeting. Council members should feel free at any point in time to just unmute and interject with any questions that you've got. We'd love to hear them as we go along.
Hi, Ray.
Sorry. Hey, David, welcome.
Sorry, I joined a little late and caught the tail end of your report. But did just want to mention to you that the analysis on variation of spending by patient zip code is something that we're also thinking about too. So maybe a good opportunity for some collaboration. I think one of the things that we're also thinking about with that analysis is not just the difference in spending levels, but where is that spending happening? Is it happening in primary care? Is it happening in the hospital? And we may see differences in kind of utilization and spending patterns underneath that that may indicate higher or lower value of kind of the healthcare services being received. So so excited that we're thinking along the same lines, and appreciate your work on all of that.
Great. And so, we had this great meeting not long ago where we talked over just all the different topics that the organization, that the Health Policy Commission and CHIA have that are, synergistic, overlapping in a very positive way. So this seems to be another one that if you guys are going to do the analysis, that I think we would just want to talk to you about making sure the data is what you need for the analysis, as opposed to trying to, do a separate analysis. So we should, add that to the agenda for the next HPC CHIA, interagency discussion. Excellent. Does anybody else have any other questions or comments? Meredith.
Yeah, Ray, I was just curious, and maybe this is just a big picture question for you to think about, is what you've been learning over the last, I guess it's been 6 months now, that you think will affect the way CHIA operates in the future. I know for many of us, despite the obvious downsides of the pandemic, there are some obvious efficiencies that have surfaced, and I can imagine for CHIA that might be the case as well. And of course, I know Deb's going to talk to us more about the new way of distributing data. Seems pandemic proof in a way that the old way, not so much. But I'm just curious both the scale of your operations or the way staff work going forward will look different even after we, knock on wood, get back to some degree of normalcy.
Right, it's a great question, and sort of I'm kind of very curious to find out myself. I think we have the luxury. We are we have to be in one of the very upper percentiles in terms of the strength of transition we've made to remote work. It's really been just an undiminished. Now, I do think there are downsides. So onboarding people, and I think that we're going to do some outreach to our staff this fall to understand better. Like, I think not everybody loves being alone or working from home. And we really want to understand the mix between people that like it and don't like it, ways we can just make it better for the whole workforce. Because I think we don't want to ignore the downsides. But from a pure productivity standpoint, we're doing more work than we were doing in February, for sure. And so I have to believe that our future will not involve just all of us going back en masse 5 days a week to the same location in downtown Boston. So I think it's exciting. I think that we aren't under the gun, like we aren't, the services we don't require us to be there. So I think for us, it might be very different, but we also are a public sector organization that comes with, I think, some just obligations and limitations probably. And so, we're going to be a fast follower. I think we'll see how this develops, but the good news is we are in a very strong position from a productivity perspective that we don't have to force the return. Any other questions on anything I've said or anything else? At any point in time, feel free to throw in any questions. It's an open forum. But all right, well then, why don't we turn to the first more of a slide-based presentation, and it's from Deb Scheel, CHIA's Chief Analytic Officer, and an update on the All-Payer Claims Database project.
Thank you, Ray. It's so nice to see everyone. I hope everyone's been healthy and safe. As Ray said, the core team has been working really, really hard on this project. I don't think anything slipped. We just have gotten used to sitting in front of our Zoom meetings for hours and hours on end with our partners, IBM Watson Health. So, and it's been long hours of requirement sessions, user acceptance testing, and of course, the database development and data mart development, both from an Oracle standpoint and from our Tableau data sources. So we'll talk a little bit about this, but I want to update you on the timeline and where we're at. As Ray said, we're getting close to our production environment. We'll discuss that. And then also want to remind people kind of what you'll be able to get out of this. And initially, our production kind of environment, the initial phase of it, and then what we hope to get out of it when it's fully operational after release 9. So when we left off a couple of months ago or several months ago, we had again finished the project initiation last year. Many requirement sessions have been taking place, and release 2.3, we have the ability to report on commercial and mass health member months and metrics related to the enrollment characteristics and demographics of those members. So again, the most challenging piece was our eligibility data. IBM typically sends out a specification and the health plans can meet that, but they had to kind of back into what our specifications that we can't change. And again, it's very complicated. You could have a 30 row record for one member, and the resulting of that is that they have 3 member months for Harvard Pilgrim for an HMO after all that work of cleaning up the data. So we have now the ability to report commercial and mass health members by various membership characteristics. That was completed in March. We're using a sample data set for both mass health right now in a user acceptance testing environment with 700,000 lives for 2015. Release 4, we moved on to have the ability to report off of commercial and medical claims and financial metrics, again, linking all the national reference files, including ICD, CPT4, revenue codes, all those national data sets linking to the medical claims. That was completed in June, again, using a sample of the commercial 500,000 commercial lives in the UAT environment. And right now we're right in the middle of release 5 and 6. We're working on both of these simultaneously. And now we have the ability to report commercial, medical, and pharmacy claims, financial metrics, again, with national and reference files and eligibility dimensions. Again, claims typically don't have the demographics and level of detail on the eligibility like the employer group, or whether they're fully insured or self-insured on the claim. So all that is linked together. And I think anyone who's used our data, just linking all these things is a monumental task. So that's been accomplished. And again, we have 2 levels of users, the Oracle or the SQL developer who can use R, Python, any kind of more sophisticated programming, or Tableau for what we're calling Explorer. Access to data through the Tableau, kind of our BI tool solution. And that's getting ready. We're right in the middle of user acceptance testing of the medical and pharmacy claims and financial metrics with both eligibility and the national reference files. And again, it's on the UAT environment and historical data in 2015. And then release 6 is including both mass health and commercial, medical and pharmacy claims, and also allowing us to do dynamic per member per month calculations, which has been a little bit challenging with Tableau. It's not typically set up to do that. So we have a solve for that, or IBM has created a solve for that. We're hoping we can get that a little bit more user-friendly, but we can do dynamic PMPMs. And again, we're just starting UAT on that. But the other exciting thing is we'll be moving, IBM's moving not only to the UAT environment with sample data, but they're also moving to production environment with data from 2015 through December 2019. So we're excited about that. And all this functionality from 1 through 6 we'll be able to access in the production environment probably in November. And that'll allow us to have, several months of using it before we add the enhancements. So the enhancements, so up until this point, you can do financial, you can do member months, you can do PMPMs, none of the kind of the sexy stuff like risk adjustment, episode groups, discharges and things like that won't come until release 7 and 8. So we just wanted to let you guys know that. So that, and then we're also doing requirements at that. We've started those as well. So as we're doing requirements for 7 and 8 for the enhancements related to flexible analytics, which is the IBM product, we'll have access to this production environment for everything in the previous releases. And then I just wanted to remind people of what we'll get out of both after release 6, what you'll be able to have access to, what we'll be able to produce. And again, this will be 2015 to 2019 data, full production. It's still, we're going to be kind of beta testing it. Hopefully we'll be able to use it for some products. But again, we're going to be a little cautious. It's the first time it's going to be in the full production environment. But we're excited about this piece of it. Again, Tableau users and Power users will have access to this. There'll be a number of different data sources that are set up. So for release 6, which will be coming out shortly, we'll be able to report again, how many members do we have by HMO, PPO, by plan? What are their characteristics? What's their group size? We'll be able to trend mass health membership by various mass health indicators. For the medical claims reporting, we'll be able to report both total paid, plan paid, and patient out of pocket, again, by those various eligibility characteristics that we talked about before. We'll also be able to report, more clinical breakdowns within these data sources. So you could take a look at the spending by various diagnostic groupings, basic groupings, nothing fancy like we'll be getting with the flexible analytics, but provider groups will be able to report behavioral health spending, non-behavioral health spending, both pharmacy and medical claims. Again, we'll be able to report the pharmacy data, number of claims, number of scripts, total paid, plan paid amount, patient out of pocket, and average cost per script, both by the individual drug at the NDC level or drug name, by generic or brand, or by therapeutic class. Again, they've added the Red Book, which is an IBM product, to this solution. So by release 6, we'll have all that capability. I just want to remind folks, it's mostly fully insured. We still haven't gotten the self-insured back. We'll be able to report, and this is kind of a broad breakdown, but if you want to take a look at asthma and how much is spending on asthma, this is kind of rough, but you'd be able to report for those those with an asthma primary diagnosis and those with and then those that are taking a respiratory drug, and be able to kind of estimate how much spending is in that classification. So that's just an example. You could do behavioral health, but it's a rough estimate. When we get into true medical episode groups, that'll be in flexible analytics, and we'll talk about that next. And then we'll be able to do PMPMs again, plan paid PMPMs, out of patient out of pocket, again by HMO, PPO, or if we want to look at different groupings by I don't know, employer size, for instance. But when we get into the after release 9, we'll have a lot more of the enhancements that we've been looking for. Again, zip code and geographic region, I just put that as a reminder because we have some work that we have to do on zip code related to de-identification. But we'll have member level risk scores that we'll be able to include in other analytics. Again, we'll have more PCP attribution. We'll be able to roll into health systems or groups or provider groups. Medical claims reporting enhancements. Again, here's where when we get into after release 5, we'll be able to report by service category. And there's a different levels of hierarchy with service categories. So inpatient, outpatient, lab, radiology. We'll be able to report, by episodes for the first time, visits, discharges, average length of stay, DRGs will be included. So we'll be able to report, for instance, number of discharges, total days, average length of stay, and cost per admission or discharge by plan, by hospital, by DRG. And then some other ways when we have the medical and the pharmacy linked together. This is where we'll have a member 365 reporting for a year. We'll be able to take each member and be able to track how much spending they've had. Probably some level, HPC has already done this. We're trying to recreate this so that you can see who are the top members who have the most spending, how many ER visits do they have, how many discharges, that type of thing. Also, we'll be able to have medical episodes for the first time, where before it was kind of a rough estimate on spending for an aggregate for, let's say, asthma or behavioral health services. This you'd be able to take a episode, for instance, like asthma, and for that particular clinical episode, you'd be able to see what the services were and what the spending was for pharmacy, and you can break it down by like service category for that, and you'll be able to compare by provider or health plan how those patients are being handled. And then finally, medical claims, PMPM for reporting, will be able to do things.
Hang on, Deb, if I could just interrupt for 1 second. I think I see a question. Bill Geary?
Hi, Deb, it's Bill.
Hi, Bill, how are you?
Good, how are you? Thanks for all the great work here. Just a quick question more with regard to Watson. I mean, we're all familiar with kind of their well-chronicled issues and shortcomings, in particular with regard to healthcare and some of the things they've built and turnover in the team. And wondering how much of that you're seeing. Are there concerns there? Are they doing a lot of this work from scratch?
Yeah, great question.
Are you worried about that? And again, the team has kind of continued to turnover, just generally, I'm not speaking to the team that you're working with, but just in general, we've seen it, throughout the industry and certainly in some of our companies. So what's your take on their ability to deliver?
Great question. I think we've kept the same team. The team, unfortunately, we should risk adjust them because each person on the team has had some level of surgery since from knee surgery to neck surgery. So, but they see it's the same team that we've worked with. They've added people. I think this is new for them. Tableau is new for them. But I want to remind everyone that out of the 13 bidders that we got for this, 12 bid Tableau as their BI solution. So I think we would have wound up with that as the issue. Certainly our membership was unique to them, or the way that we get resubmissions was very unique. So that first part that I think we talked about before of member eligibility was a real struggle. But we completed that piece of it and that phase of it. Again, they've been pushed on in terms of timeline. This has gone beyond where they hoped it would be, but we're getting there. But and we've done a lot of the solutioning for them. But on the claims piece, and again on flexible analytics, that's their product. So now that we have, I think, the underlying data models and they understand our requirements and our data better, it's been going a lot faster. You see these deliveries coming a lot faster. But they've been with us and honest, I think, transparent partners to us. And again, we get pushback sometimes where they're like, this is what we're delivering. We're saying, nope, that's not what we want more. So we're pushing back on them in terms of that. That was a great question.
Got it. Helpful.
And but my take on that, I mean, at the kind of strategic level of the partnership, I've actually been pleased. I mean, on the one hand, this has taken longer than we originally expected. And there are parts of this that we are clearly the subject matter experts for the solution, which I think we didn't really plan on that. Like we didn't factor that into our thinking with, the allocation of resources. On the other hand, what we are asking for is remarkably complex. What we're getting seems to be, once again, very consistent with our original vision. The team they've shown just great commitment to us and to the project throughout. So whenever there've been difficulties, at no point, sometimes you feel like, we just lost them, like you've had those times where, or not because of something you did, just like, the corporate office just swapped out your team on you. We've had remarkable stability of team, and whatever bumps and, zigs and zags we've had, it's been kind of a roll up your sleeves. How do we get past this? So I would, at the strategic level of, how have they performed as partners? I think we are very happy. I mean, now, the proof of the pudding is in the tasting. We're just about to get there, but whatever difficulties they've had as a larger enterprise, our project has really gotten good services, I would say.
Yeah. And the complexity is we want to be able to have the power users be able to use the complex data model and there's a lot in there. There's, so much so that it's overwhelming and it's complicated. So the tough part now is making it uncomplicated for both our Explorer users to be able to jump on and say, okay, I understand where all the fields are in Tableau. I understand, how to pull things. We had as was requirements. So you could always go back to something. If we had a resubmission, you can tie back. That's very complicated. They take it to heart, our requirements, but that could be very complicated if you have to toggle, I want this data file from way back here before this resubmission. So we're trying to make things as uncomplicated as possible so people can jump on both for power users and for explorers, but then people can also dive in and really get into more of the complex nature of the data.
Deb, on that point, I was wondering
Sure.
about kind of like your Explorer users and potentially service delivery in Tableau. So with Tableau, are you guys kind of like pushing out like custom Tableau dashboards like within your environment and then people are accessing them? Or are people going to be able to kind of like go in and kind of like create in Tableau? And is there like a licensing issue for outside users potentially, or?
Great question. We are trying to create a drag and drop scenario and try to stay away from Tableau dashboards. We want people to be able to access as many of these, the fields and functionality as possible. And and the dashboards can be very limiting. You can just do by plan, and the drop down and the filters are very minimal. So we're trying to make this so that someone can really drag and drop and do filters on, I want spending, for asthmatics for that just particular diagnosis for these 3 plans, to be able to be as nimble as possible, but also keep it as user-friendly as possible. So,
right. And will users need Tableau on their end, or will they be able to?
Yes, it's
Okay.
going to be on, when someone enters in, it's going to be on their server. So when you portal in, and again, all the security, role-based security will be, it'll be very similar. If a sister agency comes on, they'll have to fill out a data use agreement, and whatever fields that they're allowed to use, that will carry on to either Tableau or the Oracle database. So that should be, they'd only be able to see that level of detail.
Got it. Thanks, Deb.
Thank you.
I mean, we're working most closely with the HPC as a sort of external user because they're the closest to being ready, and they're a power user. But this isn't right unless it works for like the core state agencies with strong healthcare interests, and certainly the appointing authorities. The Attorney General and Auditor's Office, get a front row seat automatically. So you can be sure that however this is architected, it will be a solution that works for you folks.
Thank you, Ray. Appreciate it. And I like your headphones, Deb. But
Oh, thank you. I have very flat ears now after 9 months.
nice.
Right. Now, Deb, actually, I think the next slide we're going to have to run through quickly because we're.
I just did that. Yep, I did that slide already. Yep.
That's what I thought. Okay, so you've
We're
spoken
good.
to these points.
Yep.
Do people have any further questions on the APCD project? All right, it's really, so you'll see there's just an interrelationship between everything kind of that you're going to hear about. So now Andrew Jackmaw, CHIA's Chief of Staff, is going to give a quick update on a whole range of activities that we've been performing for the Commonwealth's Command Center. And it's very interesting and important work. Every agency has had to step up tremendously during this pandemic, from the Department of Public Health, who's really on the front lines. CHIA kind of less so. We weren't set up to be a public health agency to do surveillance. We were really more looking at the finances of the healthcare system. But we've pivoted, as you've heard, or you'll hear even more about, accelerated reporting so we can get a faster look at things. But we've also just flat out supported a whole bunch of activities from the Command Center where we have particular expertise that we can bring to bear. And as I said, we're not the only agency that's doing this. So Andrew's going to give a little report on the different things that CHIA has done during this all hands on deck exercise. And with that, I'll turn it over to you, Andrew.
Great. Thank you, Ray. Can everyone hear me okay? Okay, great. That's a promising start. So I'm going to try to do this in 5 minutes or less, just because we have a stacked agenda today. But that may actually be challenging because there's a lot that could be said about CHIA's continued role in supporting the state's COVID-19 response. So we'll see how the goal of brevity goes. Now, very shortly after settling into our new remote work environment, CHIA started looking around for opportunities to apply our ongoing data collection and analytic efforts in support of the state's pandemic response. And in particular, the then newly formed COVID Response Command Center, which was being led by Secretary Sutters. We started by modifying, as Ray mentioned earlier, a few of CHIA's data collection efforts to offer some more rapid insight into the impact of the pandemic on our state's healthcare system. Firstly, back in April, CHIA asked hospitals to consider voluntarily submitting case mix data to provide an early look at how hospital visits were evolving through the early months of the pandemic. And since then, CHIA has been working with about 15 hospitals to collect monthly data submissions. These 15 hospitals represent just under a quarter of acute care hospitals in the state, which is really great when we consider that we would otherwise only be able to access data 90 days after the close of the previous quarter. So we are very much appreciative of the hospitals that have elected to participate in this voluntary effort. Secondly, our enrollment trends data, which had previously been published twice annually, has now been updated to include some monthly summary reports that track key market sector performance on a month-over-month basis. Just yesterday, actually, all members of the council should have received a copy of our latest report with data through July, which kind of notably found that overall insurance coverage in Massachusetts has remained relatively stable through the pandemic, although there are some, we are seeing variation among market sectors, notably a kind of decline in commercial coverage that has corresponded with an uptick in mass health enrollment and enrollment in some of the programs for dual eligibles. And then thirdly, we have also modified our hospital and health system financial data collection efforts to include voluntary monthly submissions. And as Ray mentioned earlier, later today, you will be hearing from Liz Almanzor, who will provide some more details on this work. Now, with respect to specifically to command center-led efforts, a few staff from CHIA were brought in to help lead the process of matching medical volunteers with providers who had need for temporary staffing assistance. That kept a couple of us pretty busy throughout the months in the spring. And as the pandemic has entered a kind of quieter phase here in Massachusetts over the past few months, that work has started to ramp down. Perhaps most notably, CHIA has been working to assist the command center's nursing facility accountability and support initiative. What this is a package of resources and financial incentives that have been coupled with accountability measures for patient safety to help address factors that have contributed to high rates of COVID-19 among nursing home residents and staff. One of the key aspects of this effort has been the deployment of clinical rapid response teams to help provide direct care for residents and support for nursing home administrators with the greatest need. About 100 travel nurses were brought into Massachusetts at the high point and assigned to one of 10 teams. And CHIA has been working to help support the logistics around managing these teams, including coordinating PPE drop-off, hoteling, transportation, and things like invoice processing. In addition to this, CHIA has also been collaborating on a daily exercise to understand how well nursing homes are meeting their accountability measures. We've been working on a cross-agency effort to collect, normalize, and interpret data from these disparate sources that have then been fed into some performance dashboards and some of the public reporting that you may have seen. In addition to this, CHIA is also currently working on a regression analysis to evaluate the factors that may be contributing to increased COVID-19 cases and deaths in nursing homes in Massachusetts. The results of this analysis are still forthcoming, so I think we will have more to say at a future point. But in general, ensuring the quality of this type of reporting has been really essential as it helps inform decision-making around resource allocation and supports for facilities that provide care to some of our most vulnerable residents. So it's something that our staff has really worked tirelessly, and I think taken a lot of pride in being able to support. So that's been a lot of work, but something that I think we've been really enthusiastic about being a part of. And again, as a reminder, as Ray said earlier, last November, CHIA had produced our first analysis on the performance of Massachusetts nursing facilities. And at that time, our intention was to replicate the report on an annual basis going forward. But really since the spring, what has effectively happened is that we have been producing this type of analysis on a daily basis. So our involvement in supporting the state's pandemic response has really forced us to put a lot of our data collection and analytic capabilities on steroids. And I think it's been really exciting to see what we've been capable of pulling together with some urgency here. So I'm going to stop there. I don't know if I actually achieved 5 minutes. There's certainly more that we could say, but I recognize that this is already a lot. So Thank you for your time. I'm happy to answer any questions that the council might have.
Andrew, I just want to sort of chime in here and express sort of the gratitude and level of appreciation that for CHIA's willingness to sort of step up and partner and really kind of provide resources and leveraging and offering sort of your strengths as an analytical data collection reporting agency. I mean, this truly has been an all hands on deck. And so obviously some of the things that you mentioned around the rapid response teams and the clinical, the coordination with for staffing is sort of more generic. And that's an example of, again, CHIA's willingness to step up and offer multiple hands for this all hands on deck initiative. But as the person sort of leading the nursing facility efforts for the state and the state's response, I'm a direct beneficiary of the resources that CHIA has provided to that initiative, and we really would not be sort of where we are in that the accountability and supports proposal without the help of CHIA. So it's been, your efforts have been tremendous, and I just wanted to make sure that the council was aware of all of the work and resourcing and partnerships that you've provided. So again, very grateful.
Oh, thank you so much. That means a lot. Really, really appreciate that. Awesome. Are there any other questions on the work that we're doing with the command center? I meant to say that the APCD that Deb was describing, if you just start to think about turning that tool on some of the questions you want to know, like about the delayed services or different populations or different diseases or different, encountered, like it's going to be an amazing tool for the work we do, going forward on this terrible disease, or terrible virus. So anyway, thank you very much, Andrew. If nobody has any other questions, we'll move on to the next item. Everybody all set? All right, so that brings us to you, Emma. Emma Schlitzer is going to give us an update on the health reform legislation that is still pending before the legislature, but whatever version emerges, we feel confident that we'll have some interesting and important work for CHIA to do, very often in partnership with the Health Policy Commission. And we look forward to that, and we feel like we're well prepared. Famous last words, but no, we feel like we're in a good position for what the legislature asks us to do.
Thanks, Ray. Nice to see everyone. I will also aim to be brief in the interest of time. So just to start with a quick overview of this current session, starting in the Senate, they did pass 3 healthcare bills that included some additional roles and responsibilities for CHIA. The first one was a bill that addressed pharmaceutical access and costs. The second one dealt with mental health services. And although both those bills passed the Senate, they did not get taken up in the House, which would have been the next step in the legislative process. The third bill, S2796, an act putting patients first, is where we're going to kind of focus today. That was largely centered on telehealth. The House did pass its own version of that legislation in July. That was H4916, an act to promote resilience in our healthcare system. So just to touch on the overlap between the two bills, there was a good amount of overlap in general. I am just going to focus on the CHIA-related sections. So both bills called for a study on telehealth. That language directed the HPC and CHIA to evaluate the impact of telehealth on healthcare access and costs. The second area of overlap was in regards to out-of-network billing. The language in the bills did differ a little bit in their approaches for this. In the Senate version, it asked CHIA to determine the non-contracted commercial rate for emergency services and non-emergency services, while in the House language directed DOI in conjunction with CHIA to calculate out-of-network rates based on a percentage of the average rate carriers pay for a service. And then to look at a few of the differences between the two versions of the bill, the Senate bill called for 2 additional studies, the first one being a COVID-19 study. That language, again, tasked HPC and CHIA to study the effects of COVID-19 on the healthcare system, specifically the effects on accessibility, quality, and cost of healthcare. The second study pertained to dental therapists that directed DPH, HPC, and CHIA to evaluate the impact of dental therapists on patient safety, cost effectiveness, and access to dental services. Moving on to the House version, that had a section on hospital payments. That language utilized CHIA data to determine which hospitals would be eligible for enhanced Medicaid payments. The CHIA data that's referenced is relative price, payer mix, total net assets for hospital and health systems, among other metrics. So that about sums up, obviously there's a lot of other sections in the bill, and that about sums up the CHIA related sections. Where things currently stand is that the bill has been referred to a conference committee, which is comprised of 3 senators and 3 representatives. Their goal is to resolve the differences between the 2 bills to come up with a final bill that can then be sent to the governor. As Ray alluded to, we're not quite sure what the final bill will look like. We have been tracking this legislation just so we are prepared when the final version does come out. But that is kind of where it currently stands, that we're just awaiting to see what the final language will direct CHIA to do.
Just a quick question. Great summary on this. Ray, with regard to the telehealth kind of overlap of you being able to look at data and understand, access, cost, are outcomes the same? Are you really readily able to deliver on that? It's kind of a tall order. Lots of those studies have been done. A little hard to get kind of a control group to really understand. But do you think you're going to be able to deliver on that? And if so, like, just quickly, how can you do that with the data you have access to?
I think maybe what I'll do is turn it over to David Seltz first, unless that's a dodge, David, only because I think it's really, is this the one that HPC will more take the lead? But I mean, I can tell you what my take on it would be, but I think this is likely to involve the HPC in the lead with CHIA as sort of the data sourcing. And so you want to maybe first take a shot at that, David?
Well, I think the question was about data, Ray. So I think
well, then, okay, then happy to take the data view of it. Well, so I think that the answer, Bill, is that we'll be able to, there's a number of things we will be able to measure, right? But I mean, of course, the clinical effectiveness of telehealth versus physical visits is not going to be one of them. So the legislature will often write a bill that, it may in some sense be aspirational, but we take it as, and I say it'll be the CHIA and the HPC, or potentially, depending on, which study we're talking about, but for the telehealth. And I think we'll, try to understand what we can in good faith, give them based on what we've got. But I think just with, it'll take a little bit of time for this to pass. I mean, we have to look at the deadlines of the final bill, but the new APCD, if you're only looking to sample a bunch of data as opposed to do a full measurement, that could provide some really interesting information about this. Our aggregate data, I mean, we can get the health plans to report to us about telehealth on an aggregate basis. We have a lot of tools at our disposal. So I feel like we can do really good work. We can be very responsive to what the legislature wants. But I think there's going to reach a point where just kind of we can't go there. But the HPC has, does bring in clinical expertise and it kind of goes further than just CHIA data. But I think the legislature will probably include some things that they would like to know that maybe the 2 agencies can't quite get to. But I don't know, David, do you have any additional thoughts?
Yeah, I would just add that we have already done analysis in the past on the APCD where we can see the telehealth code, and so have confidence that the APCD will be able to help provide a lot of insights because we've already kind of splashed around in that pool a little bit, and all of the enhancements that Deb talked about earlier, I think will be just really critical to helping us think through this. The one thing I would add is in addition to kind of the claims data, we are also pursuing some partnerships to do some survey work as well around provider experience, patient experience. We think that can be an important lens to incorporate into this thinking as well. And as I think, as Ray said, kind of going, Bill, question by question and trying to say, mapping, okay, what's the data? Do we have it? If we don't, how could we get it? How could we do it in a way that, is reasonable in terms of not having additional burden, but also understanding the telehealth questions are critical. And every state, I think, is really thinking about telehealth payment policy, coverage policy, modalities. I think an opportunity for HPC and CHIA to even look beyond our two agencies to think about how other organizations are really wrestling with these questions. So just a little bit to add to Ray.
Yep, very helpful.
Excellent. All right. Anything else, Emma, on the legislative update?
No, I think that about covers it.
All right. So that's not, like I said, we've now got a video montage. Andrew, I don't know if you want to do an introduction. Actually, well, one thought I was going to say, we are a little bit running late on time. We could send a link to the video is one thought. I'm wondering.
Yeah, Ray, given where we are in the agenda, I might suggest that because we have the luxury of sending council members a link to the video montage, there's a benefit of recording it, is that they can watch it kind of at their own leisure. And it really is just to give, the council a flavor of the posters that were presented, posters and abstracts that were presented at Academy Health and NATO. So I think we can send that to them and they can kind of watch it at, time allowing, and, we'll be happy to answer any questions that may raise.
Okay, let's do that. I think that, yeah, we would really like to, as I've said, showcase the breadth and depth of CHIA's kind of agenda and talent. But since that is, recorded and we can share with you via link, let's do that and move on. So actually, it'll be Emma, you again, talking about kind of a retrospective on CHIA's recent publications and a look ahead to things that are coming up. So why don't you go into that?
Yes, so as Ray mentioned, and again, a lot of these topics have already been touched on, so that this should be pretty brief. In terms of our publication, since the last time we met in June, we have been doing a lot of work with health insurance enrollment reporting. Andrew had mentioned our new series on monthly enrollment monitoring. We have also continued our more detailed biannual enrollment trends reporting. Both the most recent enrollment monitoring and the most recent enrollment trends report did come out yesterday, which hopefully you all saw that email. Moving on to our reporting on hospital financial performance, we did release a quarterly report back in early July that had data through the end of March. So that did cover the first few weeks of the pandemic. And then we did kick off another new report series to provide more rapid insight into the impact of COVID-19 on hospital finances. That was accomplished through voluntary data submission from hospitals. And we published our first report on that, I believe, at the end of July, and that had data for March, April, May, and did include COVID relief funds in that reporting. And then in mid-August, we did release relative price data statewide and hospital for calendar year 2018. So looking ahead, we do have a lot coming up. Again, more reporting in the hospital financial performance realm. Our next report will be our FY 2019 annual report, and then moving on to additional monthly analysis and then quarterly reports coming up in the next few months. We will also continue to publish monthly enrollment monitoring on a monthly basis. The next report next month will have we'll have data through August 2020. And then lastly, later this fall, we are going to be publishing our third report on behavioral health and readmissions in Massachusetts. That will use state fiscal year 2018 data. And then lastly, we are working on a new report series, an annual report on Massachusetts acute care hospital case mix data that will be using FY19 data. And I believe the first report will be focused on the hospital inpatient discharge database. And that'll likely be in December.
Do people have any questions or comments on any of those publications? I know it's a lot to go through, but it's like just single bullet items. The behavioral health and readmissions in Massachusetts acute care hospitals. I don't know how long I'd been at CHIA before I realized it starts with a really good description of the presence of behavioral health comorbidities among people in hospitals because we have that data. So it's not looking at the whole system, But if you want to really understand the presence of behavioral health, like how common it is, which diseases, and what it's so different characteristics, our hospital readmission study, in fact, starts out with a really rich foundation of data about behavioral health, the presence of behavioral health conditions among people that get hospital services in Massachusetts. So just one bullet point, each one of them is just really a gold mine of information. And I want to emphasize, CHIA has not dropped a single data collection, not a single publication. In fact, we've accelerated both data collection and we're adding new publications to respond to these demands. So really good work by the team. It's sort of too bad we can't give each of these more attention, but we're going to turn shortly to, in fact, next to some of the publications that CHIA has done that we can give you a better sense of. But before doing that, do people have any questions on our recent publications? David, it looks like you might be.
Yeah, just a really quick question. Thanks for the update, Emma. Do you have a timeline for the annual report? I know that's likely in 2021, but where are you tracking with that report?
I believe we're looking to in February of 2021.
Thank you.
And we can absolutely, we'll keep you guys informed on a, sort of ongoing, basis. But I think we've, with the holidays, I think our sense was that it was going to be too hard to hit the end of January, but that it would be, looking like a February. But certainly we'll be in close contact over that. All right. Okay. Well, so you've heard a lot about a lot of different things so far, but so now we'll focus in more specifically on just one activity, but it's an example of how we've really modified things that we do to respond to the emergencies that we're currently experiencing. So hospital reporting, generally you're really just looking at the annual financial condition of hospitals. Maybe there's some sort of a quarterly component to it that's of interest, and certainly I don't want to minimize it. I mean, hospitals are important, complicated institutions. They, so there's a lot of financial stresses, but there's nothing like a pandemic to completely change the level of interest people have in wanting to understand what's happening to hospital financials. And so CHIA took what had been, kind of an exercise that was really quarterly in nature, I think, quarterly and annual. And we've now set up voluntary monthly and quarterly and annual reporting, and we're asking new questions. We're getting at whole new categories of data because we've been contacted by lots of people wanting to understand what funding hospitals have received from the federal government and state government, and are we accounting for that? So we've really scrambled to roll out brand new data collection and reporting around hospital finances on a monthly, quarterly, and annual basis. And so what I want to do is turn it over now to Liz Almanzor and Mary Burns, two people from CHIA's provider finance team, and they'll talk about, I think, both kind of the data collection aspects of this and then the actual results of what we're seeing so far in terms of the impact of the pandemic on hospital finances. So Christine, take it away, or Mary, whichever of you.
I think I'll take it. That works for everyone. So thanks, Ryan.
Liz, I'm sorry, I completely
You got
transposed.
extra people.
Liz
This is what happens when the whole team.
Forget, that was what a horrible. No, Christine will be doing a presentation later on the health insurance survey, and I transposed. Liz is from our provider finance group. She's been doing great work on this accelerated reporting around the hospital finances. And so, Liz, please take it away.
I mean, if Christine wants to do the presentation, I'm all for it. I won't complain. No, I
Maybe
appreciate
switch presentations in real time just to see how it goes.
So I'm going to give what will hopefully be a high-level overview of what we learned from the hospitals in the first couple months of the pandemic. So as Ray had sort of mentioned, we collect financials from the hospitals and their either parent organizations, their health systems, and their physician organizations on a quarterly basis. So those reports are typically due about 45 days after the quarter ends, and we typically report out another 45 days later. And normally that gives you a solid picture of what the hospital financials look like. But in this year, we're sort of in a very unique time where we wanted to get a more timely look as to how the pandemic has impacted each of the hospitals. And so back, I believe in, I think, April, we started working with the hospitals and some other stakeholders to put together a voluntary monthly filing that would begin with March, which was the beginning of the state of emergency in Massachusetts. And these reports are only collecting the statement of operations data. So it collects information on revenue, on expenses, and then the corresponding profits and loss at each of the hospitals. We had requested that this data would be due about 30 days after month end, so a much quicker turnaround than we're usually used to seeing the data. And then one thing that we had actually gotten a lot of feedback on was if we could isolate all of the relief funds that hospitals are receiving and then look at how operations would have been impacted with and without these funds. Because in many cases, particularly with the federal funds, they had major impacts on how each month looked. So our first report was published in August, and that reported on data for March, April, and May. We were fortunate enough that 38 of our 61 hospitals participated voluntarily. And those hospitals actually represent 74%, so almost 3/4 of acute hospital revenues in the state. So it was a solid picture. And
I have,
so
I
these
have
are
a
sort of
question
some-
about that.
Yeah.
Was there a consistency of the 23 that didn't report? Are they smaller? Are they not? The teaching hospitals, is there?
Some are smaller. There is, on the next slide, you'll see sort of the breakdown of how the hospitals, whether the academic medical centers, the teaching hospitals, community. It was a lot of the smaller ones. I think it is an additional burden. So given everything they were going under, some were not able to complete. And we wanted to stress that it was voluntary for their participation.
Yeah, I was trying to understand the common nature of the ones that couldn't report. Was it just the burden?
I believe so. We tried not to ask for too much explanation. We were just very appreciative of those that, did decide to participate.
Happily, we do have some small hospitals that did report. So in terms of it isn't as if our view of the system is only concentrated on the big institutions. We actually have some sense, at least a sample of the smaller institutions, which we'll see.
Yes, absolutely. There's sort of a mix, I would say, across all. I don't think there was one distinguishing characteristic of who did and didn't report. So these were sort of some of the key findings. And one of the things we just wanted to have everyone keep in mind is that these are standalone monthly data. So it really only represents how they're doing in that exact month. Typically, we report on the bigger picture throughout the fiscal year. And as can be seen pretty readily in this, we had created a base period for comparison purposes. And typically the hospitals were doing pretty well in the state. And as March came along, almost all of the hospitals actually reported losses in the month of March. So 34 of the 36 hospitals reported losses in March. In April and May, which is when the federal funding started, there were some improvements, but overall, the majority of these hospitals continued to report losses to us.
Liz, you just said it, but just to confirm, so the federal dollars are included in that previous slide?
Yes, so we included the federal dollars as part of their operating revenue since that's how it's recorded. And one thing just to that point, this is more the supplemental funds. This isn't necessarily accelerated payments because we weren't able to isolate those funds at this time.
Great.
And Liz, just a follow-up question to David's, maybe the same question. If you take out the recording of the federal funds, do you have a graph on what that picture looks like, just to kind of understand the base operating improvement that may or may not be happening?
We do, not by individual hospital, but you'll see in a couple of slides, it'll show by our hospital cohort levels. So the academic medical centers, the teaching hospitals, the community hospitals, and the high public payers. And we sort of graphed what it looked like with the funds and what it would have looked like otherwise. So again, and to one of the earlier questions, that has the count by hospital cohort of whose data we received. So for example, 5 of the 6 academic medical centers were able to participate. And just on a high level perspective, you'll see in the base period that statewide amongst the participating hospitals, there was about a 3.4% total margin, which is pretty typical. I would say in this state, it's usually around 3 or 4. In March, it dropped all the way to almost negative 29%. And then again, the relief funds are included in April and May. So there is a slight improvement from March, but it's still overall negative and unfavorable compared to the base period that we were looking at. And that was across essentially all of the cohorts. So then this next piece is sort of beyond just profitability itself. What did the revenues look like at each of the hospitals? And that dark bar at the bottom is their net patient service revenue, or their revenue sort of from typical operations. And you'll see in the base period compared to the next 3 months, the net patient service revenue, as we would expect, went down considerably. April in particular was the lowest, which was really the first full month that hospital operations were impacted by COVID. And then those lighter blue bars at the top represent the supplemental funds that were received either from the federal government or from the state. And you'll notice that, yes, they of course bolstered some of the revenues they received in those months, but it still wasn't enough to reach the total expenses at the hospitals, which is that gray dot at the top. And this is just sort of another way of looking at how the operating revenues and the expenses changed at the hospitals. This gets into the cohort level as well. And you'll see we tried to scale them on the same scale. So you could see that expenses did decline slightly as they started to move farther into the first couple of months of the pandemic, but not nearly at the same rate as operating revenues declined. And you'll notice just the academic medical centers did see a slight increase, but that was solely due to how much they received in COVID relief funds. And then this was the slide I was talking about earlier, which shows the lighter blue squares at the top is where what we recorded as their sort of actual median total margin during those months. And the blue dots, which are all consistently much lower, is where the hospitals would have ended up if they had not received those funds. So across all of them, I would say it made a considerable impact as to how their overall revenues and their profitability ended up, even though it was overall quite negative.
There's one other question. Did you look at, were you able to isolate kind of cash flow impacts apart from reported, P&L, what the impact on, collections? I mean, a number of these hospitals is, and we all know, 20% or so on average, right, are patient payments. So just curious if you were able to isolate cash impact. Does it mirror what we're seeing here? Is it worse? Does it lag?
I would say day-to-day, and part of that because it is, I guess, balance sheet information.
Right.
We're expecting to find out more of that next week when we get in our quarterly reports, because those are much more comprehensive and they will include more of that information. Since this was more the strict P&L revenue expenses, I don't think we could isolate that to the same extent.
We intentionally made some trade-offs of what, we could, that point at which it was starting to create enough of a burden that we would lose participation and so on. So once again, this was a voluntary collection. So it was intentionally something that would give us a snapshot that would soon be supplemented by the regular quarterly.
So just on the basis of our next steps, we plan to take this report that was published in August and update it to now include the June and July data that we've received. We're hoping to publish that in early October. We're just sort of analyzing that data now and getting through some of that to see what it all looks like. So that'll be the next report that comes out on the monthly reporting. And then the more sort of comprehensive picture to this extent is the quarterly filing for the period that ends June 30th, and that's due next week as well. And one of the things that we had changed on this reporting is that there's a much more detailed schedule in which they're going to be filling in more information regarding COVID relief funds, as well as accelerated payments from both the state and the federal level.
That's great. Yeah, it would certainly be interesting, I think, to, as you look through kind of the cash receipts data, when you get the quarterly information, to really understand what's happening with the consumer receivables, right? The amounts are due from individuals, because I would anticipate that, that we'll obviously see, weakening there and continued weakening. And And I think many of the hospitals might not be as prepared for that.
That's a great point.
Ray, can I just make one other observation? You know, we've heard some concerns about
I apologize. I don't think I can hear you.
oh, I'm sorry, this is Eric. Can anyone hear
There
me?
you go.
Good. Can you guys hear me? Yes.
Yes.
I just wanted to, one concern we've heard about the federal COVID dollars is that the formula used, at least in part, is based on historical Medicare spending, and that may result in greater resources being provided to those hospitals that have historically received greater resources. And it might be interesting to track how those federal supplemental payments correspond with, for instance, COVID cases or COVID need, either by hospital or community, you know, with a sort of equity lens, if you will, on the COVID supplemental payments. And there's been some effort in some of the national literature. I saw a preprint about it nationally, but we have a lot more data here in Massachusetts. That might be something interesting to think about, whether through CHIA or the HPC, we can explore that issue.
Excellent suggestion. Yes, actually, we've got a meeting coming up with the Attorney General's office to address, I think, some health data issues, and maybe that'll be one of the ones that gets added to it, because I do think that's an important thing to take a look at. Is the federal funding going? Is it the rich getting richer, as it were? But we're happy for all federal funding that comes to Massachusetts hospitals, but we're also concerned about its equitable distribution. So, all right, thank you, Liz. Anything further on your presentation?
That covers it. If there are no more questions.
Any more questions for Liz? All right, I definitely encourage people to look at the publication itself. And there's another one coming shortly, as Liz said. Really good information, and with data books and such, so you can look at the underlying data. Really good information about the impact that this emergency is having on the finances of our delivery system. So keep up the good work, Liz and Mary, and look forward to hearing more in the future. All right, so now we will turn to Mike Kochi, CHIA's Chief Information Officer and Chief Data Officer. He's going to talk about, I mentioned earlier that we've replatformed, and actually moving to the cloud from our data center is actually only the latest replatforming we've done. When Mike arrived at CHIA, I mean, we run something like more than 20 data intake systems because of the various statutory requirements that have been passed over the years. And each time there was a new requirement, basically CHIA took the lowest bidder, or whoever was the CIO at the time, and that technology got implemented in our infrastructure. And so when Mike arrived, it was just a pell-mell, sort of combination of lots of different types of technologies. That's expensive. It's, it's not as scalable. It's not as reliable. And so in addition to cloud migration, we've actually spent a lot of time over the last several years migrating all of our platforms to a more modern, single consistent technology stack. And then that facilitated in turn migrating to the cloud. So a lot of interesting work going on in the IT area. I've sung the praises of how Mike's team really did a great job getting us ready for remote work. But today, Mike is going to talk, each meeting we've tended to have something with a privacy and security focus. And the way we handle de-identified data without sacrificing the power of linking data is really quite remarkable. So Mike is going to tell us about that right now. Mike?
Thanks, Ray. It's really nice seeing everybody. It's been a few years, actually, I think, since I addressed you guys. So my pleasure. And it's also really nice to find a reason to put a tie on, because it's been a while since I've been able to do that. I'm really quite excited about this service that we provide. It's an unsung service that we have that very few of our partner agencies really even understand that we do, and it really grew out of some other unrelated work, and then with some needs to further de-identify the data and protect the data, we were able to, I think, innovate in a way that makes CHIA a little unique. So I'm going to and by the way, I could easily do 2 hours on this and 100 slides. So this is the short version. Consider it a primer. If you want to learn more about this, I can spend more time in another session or in another way. So just let me know. Next slide, please. So when we looked at the APCD, one of the things that's really important in APCD is to be able to follow people's experiences as they leave carriers and move to other insurance products or move to Mass Health on and off. And so we had built what we call a master patient index for all the users, all the people, members in the APCD. There were, over 100 million different people records in 5 years of APCD data. So we used a probabilistic method and software to basically create a single ID for each person. We were able to, through that first project, take 100 million records down to 9 million individual people for 5 years, which we think was pretty inclusive of the entire Massachusetts population over a 5-year period. But when we finished with the project, we realized that not only did we have this ID for the APCD, but we also had this hub of people data that really contained almost every person in Massachusetts. Especially since when we started this project, we still had the self-insured data coming to us. So we had, a pretty comprehensive view of the insured population in Massachusetts, which is almost everybody in Massachusetts. Next slide. So we realized that with this software and with the algorithm that we developed to do probabilistic matching, that we could actually take data from other systems, the people data, and find those people in our person hub. And so the first project we did this, we collaborated with the Department of Public Health as they built their opioid study database. And they sent us, the first year was only, I think, 4 or 5 different sources. And then by the second year, it was, 15, 16 sources. And by the third year, it was in the 20s. And so we were able to find over 95% of the people that they wanted to study in the APCD. And by doing so, we were able to connect all of those data sets together to study the opioid epidemic. So DPH has been able to look at claims data along with ambulance data, along with incarceration data, along with death data, hospitalization data, all to do the studies that have driven all the legislation that they have proposed to study the opioid epidemic. And we realized that this was a great opportunity for us to expand to other linking projects using this capability that we had already built. A lot of these projects, you come up with the idea and then you have to build the thing, but we had already built the thing. So we just started looking for more opportunities to link. Next slide. So we were doing this in the clear. And what I mean by that is we had names, we had social security numbers, we had zip codes, we had, all the personal identifiable information that we all have to be very careful with. There were increasing healthcare data threats happening in the 2015 and beyond. It really just started to become this target for people looking to sell insurance information and other things, and steal identities. And so we also had this at the same time, this converging pressure on some changes to 42 CFR Part 2, which is the federal law that regulates how you protect substance abuse treatment data. And we were at a point where we weren't going to be able to keep collecting substance abuse treatment data from insurance carriers if we didn't change how we collected it. And so we also thought, as we worked with some of these potential linking projects, that a lot of the people that wanted to link their data couldn't figure out a way to feel safe sending the data with this identifiable information to us. So all of these things sort of converged around 2016, which caused us to reevaluate how we collected all this. Go to the next slide. So what we did is we developed some software that we actually deployed to the insurance carriers. We worked with with the general counsels of some of these carriers to make sure that our methods and techniques were comfortable. But we basically pseudo-anonymize the names and the SSNs and the date of births. Pseudo-anonymization is a fancy word, but what we're really doing is, for lack of a better word, using a hashing algorithm to alter those values. But the way those values are altered is, even though it's 128 characters of nothing intelligible, my name is going to get the same 128 characters when I run it through the software if it came from one place or another. So it still provides us a mechanism to be able to connect data, even if I can't actually see what the name is or see what the values are. And so we rebuilt our APCD matching engine, taking out the in the clear SSNs and names and replaced it with this pseudo anonymization system. Go to the next slide. And what that allowed us to do is satisfy the general counsels of the carriers that they could keep sending us the substance abuse treatment data. It allowed several other participants in matching projects to feel more comfortable sending us the data. So we did this great linking project for Elder Affairs where they wanted to link federal HUD data with their Elder Affairs data and some APCD data. And HUD was unable to participate by sending us data in the clear, but once we introduced this method to them, they signed off on being able to send us their data. And so they used the software that we built to prepare the files and were able to send them to us. We've been able to replicate our match success rate using these hashed values almost 100% identically to when we had the values in the clear. And so this has really allowed us to, and it's all an automatic linking service. And so we've been able to increase the number of linking projects that we do. We've got 4 that we're working on right now, and we've got several more in the pipeline. And the Department of Public Health has moved forward from the opioid database to its new successor project, which is the Public Health Data Warehouse. And this activity is 25 to 30 state data sets linked. They aspire to quarterly. We're starting with annually, and CHIA is the backbone for the assembly of that data. So they send us all sources. They don't even tell. We get all these files of data. We have no idea that they're different sources. We just they're able to anonymize that aspect of it. We are able to link all those sources together and provide all the keys back to them, and those keys underpin the connections to all those data sets in their data warehouse, which is a really cool thing that I think Massachusetts may be the only state in the US that's been able to do that. We have spoken to several other states that are very interested in learning how we do it, because the biggest issue that they tell us that they run into is they can't figure out how to get the agreements in place to share the data with each other because of the sensitivity over the SSNs and the names. So this is something that we're going to keep expanding. Go to the next slide. So we took this model and we have now built it for our case mix hospital data. So we have what we call a master patient index for case mix. And we have a linking and searchability built into that so that we can link any data set that we get to case mix. And now our third project that we're working on right now is creating a joint APCD and case mix master patient index. So rather than when we want to connect the data sets using the matching to match case mix to APCD or matching APCD to case mix, we're going to have a single ID that represents a person in both systems, which is something that will really enable a lot of new analysis. I think that I actually went really fast through those slides. I would love to tell you anything else that you want to know about how this works, but I think this is just a really special thing that CHIA has been able to do. We've got a lot of expertise in probabilistic algorithms now, and we're going to continue to look for more opportunities to use this service for the state. What can I tell you about it?
Michael, just a quick question. I mean, this particular problem of linkage is really vexing, right, for lots of organizations, states, never mind for-profit entities. So super creative on your part. Congrats on doing it. So really 2 questions, I guess. One, is there any risk of re-identification, and how have you satisfied yourself in that regard? And then number 2, have you thought about making this open source? I think it's quite creative, and big fan of kind of, not just open data, but open source. And I encourage you to think hard about that.
Yeah, so on the first part about re-identification, so the part of this relies on the fact that the people providing providing the data to us are part of the compact. And so when we give them the software, they run these values through a hashing mechanism. To get a little technical, it's a salted hash. They technically have an output that if they put into a database with their input, they would be able to see what 128-bit key that was assigned to my last name. However, they have my last name, which is why they were able to run it through our software. So we only let users use the software through a data use agreement, and it's only the people that are contributing at the moment to these state activities. Secondly, none of the IDs that we assign are actually ever given to the recipient that's using all this combination of data. They get keys that are surrogates of the matching. So anybody that is using the public health data warehouse actually has absolutely nothing that they could use to even try to reverse engineer the hash values, because they don't get the hash values, nor do they get the ID itself. They get a surrogate of even that. So really where this breaks down is if there was a bad actor within DPH, let's say, that wanted to take the source and the destination and try to figure out, what salt value we used, but they have the data in the clear. And so they already have the names and the addresses and all that stuff. So this allows us to not receive them at CHIA. So CHIA lowers its risk by not holding all these SSNs and all these names, but also because we give these surrogate values out, we're not actually revealing what our IDs are in any way. So on that. So as far as the open source nature of it, I think that the methods that we're using, when we talk to people about them, they go, "Oh, that makes sense." They go, "Yeah, oh, why didn't we try that?" I don't think that there's any special secret to how we're doing this. I think the methods we use could be adequately described in a good white paper, of which we've already written several on this. The thing that I think is unique to what we do is we do have quite a bit of experience now and success with probabilistic matching. And I think that there is a bit of art that goes with the science of probabilistic matching, and it's not something that you can just buy some software and do and get a good outcome. There's quite a bit of work that goes into analyzing the scores that you assign agreements and the scores that you assign disagreements of values as you do the probabilistic algorithm. The other thing I will say is, this is not meant to do real-time case intervention, because I am saying that this person is probably this person, not this person is this person, right? And so this is an analytical repository, longitudinal analysis, public health sort of use case. So that I don't know if that answers your question. We're certainly more than happy to share, the source of our file secure software, because the secret is in the hashing algorithm you use and the salt values that you assign, which are not hard coded into the software that we built. So there's no downside to people having access to that. I think the white paper type thing will give you an idea of what the technique is. And we've talked to Vermont and a few other states about how we do it, so that they, if they want to pursue it, they can reach out to us and we'll help them. I don't know if that answers your question, Bill.
Yeah, no, that's great.
Let me just add a little bit on each of those. So I think that in terms of the anonymization that's done, or the de-identification, unfortunately, it's pseudo de-identified. It requires a two-step. We essentially can still only share the data with people that are operating within the framework of a data use agreement. I mean, I'd love to be able to de-identify it to the point that we could just post it on the internet or share it more widely, but we have to have too many values in the data relating to date of service and race and ethnicity, where the person lives, things like that, that if we give that up, the data becomes essentially meaningless. And so we deal with the data with direct identifiers like names and such stripped out, but it's still so granular, like a person of a particular race and age and a particular zip code that had a particular procedure on a particular date. There's only one of them. And so the data is far too granular to be sort of let out into the wild. It still is used by its users under the restrictions of a data use agreement. In terms of the technology, the open sourcing of it. Number one, yes, I would love to, although having worked on a government open source project once before, it turns out people want, when they get the code, they don't want support. And one thing government does not do a particularly good job of is software support. But I think that as Mike said, I think we've built a platform. It's kind of like the original iPhone, if I'm not being too grandiose, where there was no new technology in it. It was really this beautiful integration of a bunch of things that had existed, in other forms and other products and whatever, and they just made it all work together. And so what we're doing with de-identified data, is none of it's really proprietary. It's more just like a logical sequence of things we're doing that let, the fact that we have regulatory power, there's a few things about I think the fact that we can work with the identified data as opposed to a direct service provider is a luxury we have. It also has let us explore these techniques where maybe people that work directly with identified data wouldn't. But anyway, we're happy to share the techniques absolutely as widely with anybody that wants to know.
Yeah,
all right, I think with that.
Oh, sorry. I was just going to say it really came out of the DPH's need to figure out how to do this for the opioid research, and that really created that moment for us to go, oh, we can actually make a service for this that just works. And
yeah, I'd be interested in seeing those white papers, Michael, if you have those.
Sure. We'll get those to you.
And also just happy to arrange anybody that wants a deeper dive on this, like we'll be completely transparent on everything. We're happy to set up a offline call to go through any of this in more detail.
Yeah.
That'd be awesome. I'd definitely be interested in that.
Rob, we'll consider that a yes from you. Bill, if you'd like to join, we'll send out a notice of a future discussion in more detail about our linking services.
Great, would love to, thanks.
All right, thank you very much, Mike. That leaves us with about just under 15.
Ray,
yeah, I'm sorry,
Dan. A quick question follow-up from Michael. You mentioned a couple, many ideas in the pipeline for some research projects moving forward. Have you thought about or have any initial thoughts on how this may be applied to examine the impact of COVID-19 and what some of those research questions might be that could be best suited to some of this data linkage with the public health data? Any thoughts you may have?
Well, I'll tell you that the users like DPH have been driving sort of the use case in some ways for this, and that the public data warehouse really is what they think is their platform to be able to do the work that they want to research on the COVID stuff. And our conversations, they've escalated the speed by which they're giving us data to integrate and are asking for, they just gave us another, 200 million rows of data to link because they're ramping up the PhDW to be able to look into the questions that they've been assigned to. We slowed down a little bit in the pandemic because we were replatforming. We mentioned the data center going away at the beginning of this. So we had a backlog of about 4 linkage projects, but there are a variety of things. There's a smoking cessation project that we've been working on slowly. There's as I mentioned, the PhDW. We're looking at getting Medicare data linked to case mix, which fills in the gap that the APCD has in terms of being able to look at claims for that population. And so we've been preparing for those outcomes. Part of this is a lot of agencies don't really understand that we have this capability, and so one of the reasons for this presentation and others like it is to start building awareness that actually this isn't something we're going to build. This is something that we've built and we're using actively now. That helps.
Thank you.
All right. Yeah, this capability utterly fascinates me, and I think we've only scratched the surface of what it can do in state government. And so I would love to spend more time on it, but I don't want to give any shorter shrift than we already have to the phenomenal work CHIA has done on the Massachusetts Health Insurance Survey. With the chair's permission, Faye, if this starts to go past the closing time of 12:30, I have no objection unless there's anybody sees any problem with if people would like to stay on, as questions and stuff go on for a few more minutes. I don't think we have any reason that the stop has to be a hard 12:30, unless I'm mistaken.
I have a hard 1 o'clock, but
you're still. Oh no, I didn't mean by a lot. I just meant by for this last presentation. If it be to give them a full 15 minutes or so. We may go a little over. Do you have any objections to that, Faye? You're on mute. Oops.
Oh, I think you're still on mute.
There you go.
Okay. The host muted me. I don't, but I wanted to make sure that the council members do, because we'll have to figure out how to adjourn. Can all, you just raise your hand. Can you stay past for another 15 max? Can you?
Unfortunately, I have a hard stop at 12:30, but if you have a quorum to adjourn, I think I can just drop. I think.
Great.
But as
Okay,
long
so
as there's
it's
a
all
quorum.
but Lauren is what I'm saying. Okay.
I have to drop off too.
And Meredith has to stop up. Okay.
And I do too,
David might have to.
And you do too. I'm going to say I actually have to drop off if I can. So.
Well, then, David, let's go to 12:30, but we'll sort of formally adjourn then. But for those that can stay, we may, continue to do a few more minutes of, discussion around the health insurance survey.
Okay, so I will stop with a formal adjournment at 12:30. So I will interrupt at that moment. Okay.
All right, great. I'm going to turn it over to Christine Loveridge, not Liz Almanzor, and Hong Tru from CHIA's research department. They do our surveys, and it's very sophisticated work, and it produces really interesting results. And I won't take any more of their time. So, Christine.
Hey, thank you so much, Ray, for that introduction. Good afternoon, everybody. So again, I am Christine Loveridge. I'm Associate Research Manager here in CHIA's Strategy and Research Unit and the lead analyst for the 2019 Massachusetts Health Insurance Survey, or MHIS for short. And then with me here is our Director of Research, Hong Tru, as well. So today I'm going to share some highlights of CHIA's work on our 2019 survey. Next slide. Okay, so first I'll just briefly introduce the MHIS, share some of what's new in 2019, present some of the key findings from the survey, and wrap up with some insights about what's coming next for the MHIS. We do not have time for questions, but I will gladly stay on as long as you have. So first, I can provide a little bit of background about the MHIS. Okay. So the MHIS is an ongoing population-based survey of Massachusetts residents and their healthcare experiences. CHIA and its predecessor agencies have conducted the MHIS intermittently since 1998 and biennially in odd-numbered years since 2015. We're currently in the process of selecting a vendor to field the next round of our survey in 2021. The MHIS is a little bit different from our administrative data sets. It provides critical information about our healthcare system that is not available elsewhere, including information about behaviors, knowledge, experiences, and attitudes of Massachusetts residents. So the data from the survey help to fill in those gaps in understanding on topics and issues that we can't ascertain through data sets like the APCD or our case mix data. Topics that the survey covers are pretty wide. They include health insurance coverage, the use of healthcare services and barriers to accessing care, affordability issues, the changing landscape of healthcare affordability in the Commonwealth. And then we also introduce new modules every survey year covering topics of unique or emerging interest in healthcare. So in 2019, we asked about the social determinants of health, and we asked more in-depth questions as well about behavioral healthcare. We also often field recontact surveys to the MHIS, where residents who responded to the main survey are called back or emailed with the contact information they provided us so that we can follow up with them to get a deeper look at certain healthcare issues. So we partnered in 2017 with the Betsy Lehman Center for a recontact survey focused on medical error. And we partnered with the Health Policy Commission in 2019 for a recontact survey focusing on affordability issues and potentially preventable emergency department visits. So two great collaborative efforts there. The data that we produce from the MHIS gets used by a wide variety of stakeholders, including the legislature and policymakers, employers, insurers, and of course, CHIA's sister agencies. Go to the next slide. So in 2019, just really briefly, in 2019, we introduced a hybrid survey design that included both the traditional household sampling by landline, cell, or prepaid cell phone numbers, but we also have a frame that samples households by physical addresses. We worked with our survey methodologists to implement machine learning methods to better target our sample toward the harder to reach populations. Also new in 2019, Respondents in either the telephone-based or address-based sampling frames were provided the option of responding to the survey on the web, and a majority of our nearly 4,900 respondents did so. So I can go on to the next slide. Just briefly to highlight a bit of what is new in 2019. So first, we asked several questions about residents' experiences with unexpected medical bills. We asked a few different follow-ups about high deductible health plans. We added a question about chronic conditions and expanded our reporting on behavioral health, which includes mental health conditions and substance use disorders. The 2019 MHIS has a new breakout section about behavioral health, including new questions about emergency department visits for behavioral health and a measure of self-assessed mental health status. Okay, now I'll share some of our key findings from the MHIS, starting with health insurance coverage. So the MHIS is a key source of data for tracking the size and the composition of the uninsured population in Massachusetts over time, as well as transitions from periods of insurance and uninsurance. Particularly with uninsurance rate, since the individual mandate for health insurance coverage was introduced through the health reform law of 2006, this particular survey has been a key marker for this measure. The two blue lines you can see show the uninsurance rate for the state of Massachusetts, and the orange line is the national insurance rate. Here we see that the uninsurance rate was 2.9% in Massachusetts in 2019, significantly lower than the national rate, and reflecting, several things, but in part the continued presence of that individual mandate. I should note on this slide, we have the dotted line, we have the break in the trend. Those are both methodological changes to the survey. We do believe, however, that the 2017 and 2019 estimates are comparable. It's just anytime there's a methodological update, we always say to interpret with some level of caution. So the Massachusetts Health Insurance Survey certainly explores the composition of the uninsured population. And as in previous years, we found that the uninsured Massachusetts residents are more likely to be non-elderly adults aged 19 to 64, male, Hispanic, and lower income. The family income findings suggest that many residents with gaps in insurance may be eligible for public health insurance coverage or subsidized coverage through the connector. And indeed, the Health Connector has been using our 2019 data to help inform their outreach to vulnerable populations. Moving on to some findings about the access and use of healthcare services. So in 2019, nearly all residents in the Commonwealth reported having some sort of visit to a healthcare provider in the past 12 months. That might include general doctors, specialists, mid-level providers, nurse practitioners, physician assistants, midwives, as well as dental providers. However, there are obviously gaps. Nearly 1/4 of residents said they had no visit for preventive care in the past 12 months, and a similar share had no visit to a dental provider. And then, as I mentioned earlier, in 2019, we added a new breakout section about behavioral health and expanded the reporting that we did on behavioral health. This just shows general utilization, and you can see that about 1 in 6 residents indicated having used some sort of behavioral health care in the past 12 months, either mental health services or substance use disorder care and treatment, with higher rates of utilization among females, adults aged 19 to 64, and those with family income at or below 138% of the federal poverty level. As the COVID-19 pandemic progresses, behavioral health is obviously going to be a continuing topic of enormous interest. And the 2019 MHIS, since the main survey was fielded in mid-2019 and the recontact right in December and January prior to the pandemic, this will provide key baselines on a number of metrics in behavioral healthcare utilization and affordability. So CHIA will continue to monitor trends and perform deeper analyses related to behavioral healthcare, both from the MHIS and from some of our other data assets. Next, the survey also asked about Massachusetts residents' use of the emergency department and the reasons they did so. About 1 in 4 residents reported having had an ED visit in the past 12 months, and about 1 in 10 had multiple visits. And among those who had at least one ED visit, about 5% indicated that their most recent visit was related to a behavioral health condition. We also asked about potentially preventable ED visits, a topic of deep interest to the large care health community again. And more than 1/3 of residents with an ED visit in the past 12 months said that their most recent visit was for something that they thought could have been treated by a regular doctor outside the ED had one been available.
I hate to do this to you, Christine.
Yep.
It's really unfortunate. So first, great meeting. Thank you so much, Ray. I think most of us probably loved meeting a lot of the staff members and having them giving more depth approaches. It was terrific. We're going to make a promise that we will watch the video. We will print out the last of your slides, Christine. And then I know you're going to get back to us with those who wanted to learn a little bit more about the linking the conversation we had with you, Michael. So having said all that, knowing people have to leave, do I hear a motion to adjourn the formal meeting? Wave. Thank you. Second? Meeting adjourned. Thank you. And again, sorry, Christine, you almost made it through.
Thank you, Ray. Thank you, members of the council.
Thank you.
Much appreciated. Thank you, Christine.
Thanks.
Great job. Great work.